Hello, I am Gabor Czerny. I'm giving you now part 1 of the gynecopathology lecture. We start with the vulva and the inflammatory conditions of the vulva, which are called vulvitis. You have to be aware that the skin or the mucosa of the vulva is very thin, is vulnerable to many non-specific mechanical, microbial and dermatologic conditions. A common symptom of vulvitis is itching, and scratching of the vulva often restarts or exacerbates the primary disorder, inflammation. The cause of vulvitis is often a sexually transmitted infection. The infective agents include human papillomaviruses, HPVs. As a consequence, condylomata acuminata may develop. We will discuss this later on. Vulvar intraepithelial neoplasia may develop. This is also going to be discussed. Herpes, genital herpes may develop after the infection with herpes simplex virus infection. This is a bullous vesicular eruptive disease, inflammation of the vulva. There is also a purulent or suppurative inflammation, which is often caused by Neisseria gonorrhoeae, and this is gonorrhea, gonococcal suppurative inflammation. This includes the glands of the vulva, and syphilis is a specific lesion caused by Treponema pallidum, and the primary chancre may occur at the vulva as a site of primary infection with syphilis. Non-neoplastic epithelial disorders are commonly called vulvar dystrophies, and these include lichen sclerosus and lichen simplex chronicus. Both of these disorders are associated with a white discoloration of the epidermis or mucosa of the vulva, and these are referred to as leukoplakia. Leukoplakia, therefore white discoloration or white plaque of the vulva, can be the result of benign conditions, dermatosis, so dermatitis for example, but may also be neoplastic and may hide in situ or invasive carcinomas. Only histology can adequately distinguish between these two or between several of these conditions, and therefore biopsy is indicated if you see leukoplakia of the vulva. Lichen sclerosus occurs in postmenopausal women. This is a relatively common condition. It has a proposed autoimmune etiology, and infrequently, as a consequence of lichen sclerosus, squamous cell carcinoma of the vulva may develop. Macroscopically, this is reflected with white plaques, which may be localized or may coalesce and may form a larger area. And beneath these white patches there is fibrosis of the vulva, leading sometimes to a very firm, hard condition, leading to the obliteration of the vaginal orifice as a consequence. Microscopically, the top of the lesion shows atrophic epithelium, and beneath this atrophic epithelium we see an increased dense connective tissue, and this is referred to as dermal fibrosis. Also reflecting the inflammatory nature of this lesion, there is a perivascular mononuclear lymphocytic infiltrate, which is generally scanned. The other type of lichen simplex, is a non-specific reaction of the body, which is a response to recurrent rubbing or scratching to relieve pruritus. Pruritus is a common symptom of vulvar disease, and relief of pruritus scratching leads most often to lichen simplex. This is also presenting as leukoplakia, so white patch. In contrast to lichen sclerosus, you see epithelial hyperplasia, marked hyperkeratosis of the epithelium, and there is also an inflammatory infiltrate in the dermis. It is not a precursor lesion of carcinoma. As concerns the neoplasms of the vulva, we have a benign lesion, a wart of the vulva, which is the condyloma acuminatum or condylomata acuminata in plural. These are very strongly associated with HPV types 6 and 11 infection. These HPVs are transmitted sexually, and although condyloma acuminatum is not a precursor to cancer, sometimes HPV 6-11 are associated with HPVs of higher risk, and these are associated with malignancies. So therefore condyloma acuminata reflects the risk of being infected with high-risk HPVs, leading to more severe neoplastic conditions. Condyloma acuminata are warts, so are special papillomas. They have a fibrovascular course, as most papillary lesions, and these are covered with squamous epithelium. This squamous epithelium often shows cytopathic changes which are reminiscent or diagnostic of human papilloma viral infections, and we will discuss these later on. Malignant diseases of the vulva occur in two biological forms and have two peaks in age. One is occurring in younger women. They are often smokers, and the other peak is in elderly women, and these differ in etiology and behavior. Vulvar carcinoma or vulvar intraepithelial neoplasia, a precursor to vulvar invasive carcinoma, develop in association with high-risk HPV infections, and we refer to 16-18 as being the most common ones. VIN or vulvar intraepithelial neoplasia, clinically often called Bowen's disease, precedes the development of invasive carcinoma in these cases, and this may be present decades earlier than invasive carcinoma. The second type of vulvar carcinoma is not associated with human papilloma viruses, but is associated with previous lichen sclerosus. Long-standing lichen sclerosus precedes these elderly women affecting carcinomas of the vulva. This is a picture of vulvar intraepithelial neoplasia, VIN, where you see that the whole thickness of the epithelium has larger nucleated cells which have hyperchromatic nuclei. They are atypical. You see atypical mitosis here, another mitosis here. These are located suprabasally. There is also a tripolar mitotic figure there. This is VIN high grade. And another example, which is also called carcinoma in situ, basically VIN3 of high grade VIN is indistinguishable from carcinoma in situ. This is a very subjective distinction that has been made earlier. As concerns the macroscopy of VIN and invasive carcinoma, These may be leukoplakic, which means that there is just a white plaque, a flat lesion. They may be exophytic, warty, both of them, but even ulcerative invasive carcinomas may occur in the vulva. HPV positive tumors, so the ones occurring in younger women, are often multifocal and may appear exophytic, warty, condylomatous. These are, by microscopy, squamous cell carcinomas. The prognosis of vulval carcinoma is dependent on size of the lesion and depth of invasion. If the lesion is smaller than 2 centimeters, then the prognosis is relatively good, with 90% 5-year survival. Larger lesions are associated with poor prognosis. The larger the tumor or the deeper it invades, the more common lymphogenic and hematogenous metastases are. 2 rare tumors of the vulva which are mentioned. One of them is Paget's disease, which is very similar to that of the breast seen in the nipple. This is intraepithelial spread of glandular epithelial neoplastic cells. They may be associated with an invasive cancer, but this is also a specific type of in situ carcinoma, and melanoma of the vulva is a melanocytic tumor which is similar to cutaneous melanomas, and vulvar melanoma is probably the most common non-cutaneous site for melanoma development. Ocular melanoma may be the other common site for that. This is Paget's disease of the vulva. You see the basement membrane and the dermis, dermoepidermal junction, and above this line you see tumor cells, glandular epithelial cells, which are in the epidermis and represent Paget's disease of the vulva. We get to the vagina. The vagina has a number of congenital abnormalities. We mentioned the complete absence of vagina, the division of the vagina by a septum, so this is septate vagina, and lateral Gartner's duct cysts, which may protrude into the vaginal canal. Colpitis or vaginitis is the inflammation of the vagina. This is often a transient problem resulting in discharge through the vagina. This discharge is called leukorrhea. The infective agents are bacteria, fungi, parasites, many of which are normally present in the vaginal flora, but in some predisposing conditions they may give rise to a disbalance leading to inflammation. Diabetes mellitus is a common predisposing factor. Just allowing bacteria to grow in the hyperglycemic surrounding. Systemic antibiotic treatment may kill the normal flora and may cause a disbalance leading to vaginitis as well. After abortion or pregnancy, this is related to mechanical lesions in the vagina. And in elderly persons, immunocompromised patients, the decreased immune resistance may lead to vaginitis. Candida albicans is one possible cause of vaginitis, and this is often associated with a specific curdy white discharge from the vagina. Trichomonas vaginalis is also a common cause of vaginitis, and this is associated with a watery gray-green discharge. And you can see, of course, not with the naked eye, but under microscopy you can discern the protozoan causing vaginitis from the discharge. It is to be mentioned that Candida albicans and Trichomonas vaginalis are part of the normal flora often, so they may be present without causing symptoms, and generally there is a sexual transmission of another strain of these agents, and this new strain will lead to the inflammation and leukorrhea. Vaginal intraepithelial neoplasia and squamous cell carcinoma of the vagina are very uncommon lesions, occurring especially in the elderly. They commonly associate with vulvar or cervical cancers, and this suggests that most of them are related to HPV infection. We get to cervical pathology, and the uterine cervix is a selective barrier which is often exposed to various mechanical, chemical and microbiological agents, and therefore is often the seat of disease. Most lesions of the cervix are banal inflammations, but you have to remember that squamous cell carcinoma is a common cancer in women. In the US it ranks 10th in incidence, but in other parts of the world which are less developed, this is a much more common neoplastic disease. The picture shows you the transformation zone, the squama or the columnar junction of the cervix. This is the endocervical mucosa with columnar cells, glandular cells, and this is the squamous ectocervical part of the portio. This is the locus minoris resistentiae, which is the site of most of the inflammatory and neoplastic changes of the cervix. You can appreciate chronic inflammatory cells in this mucosa, because that's where chronic endocervicitis also develops most commonly. Cervicitis is caused by a number of agents. The most common of these is Chlamydia trachomatis. This is the cause of about 40% of acute cervicitis. This leads to a mucopurulent to purulent discharge, and you have others. For example, ureaplasma is also an intracytoplasmic bacterium like chlamydia. You have a protozoan Trichomonas vaginalis, which was mentioned in vaginitis, or Candida albicans may also cause cervicitis. Gonorrhea is also a cause. Herpes simplex virus type 2 or genital herpes virus and HPV types may also be mentioned. This is a cervical smear demonstrating plenty of neutrophilic granulocytes, so this is a purulent exudate. And on this slide you can even appreciate the hyphae of fungal origin, Candida for example. Acute cervicitis is often seen in postpartum women, so after delivery, and may be caused by staphylococci and streptococci. Chronic cervicitis is much more common. Macroscopically, swelling and granularity of the originally smooth and wide cervical surface is seen, with hyperemia reddening around the external os of the cervix. Microscopically, there is a mononuclear infiltrate, as I showed you on a previous slide, and there is development of Nebotian cysts, which I will demonstrate on the next slide. The epithelium may show hyperplastic changes and may even become atypic, but this is reactive atypia, not to be confused with neoplastic changes, dysplasia. So these are Nabothian cysts, and these cysts are cystically dilated endocervical glands because of squamous metaplasia and obliteration of the final part of the gland leading to the endocervical mucosa. So there is widespread squamous metaplasia, which is one thing associated with chronic cervicitis. You see the chronic inflammatory cells being blue here associated with it, with this condition, chronic cervicitis, and these are the Nabothian cysts or follicles, these cystically dilated glands. Chronic cervicitis is very common in multiporous women if it is severe enough, and most of the time this is a banal inflammation without any consequences, but it may sometimes be severe enough to lead to scarring, blocking of the cervical canal, and leading to sterility. Endocervical polyps are often inflammatory in origin. They have no malignant potential. They are soft, smooth, glistening surface covered protrusions of the mucosa. The cut surface reveals mucous-filled cystic spaces. These are lined and the surface is covered by columnar cells. Clinically, this may result in bleeding, and bleeding through the vagina is also a symptom of endometrial or cervical cancer. So therefore, from a differential diagnostic importance, even endocervical polyps must be considered as a potential cause of bleeding from the uterus. You can see one endocervical polyp here. The surface is covered by glandular epithelium. There is a cystically dilated gland and smaller glands within the stroma of this endocervical polyp. Sometimes you can even see squamous metaplasia. Cervical intraepithelial neoplasia, CIN, and invasive carcinoma are the most important diseases of the cervix. If we look at the peak incidence in age, CIN precedes invasive carcinoma by about 15 years, 30 years of age for CIN lesions and 45 or older for invasive carcinoma. There are risk factors associated with the development of these lesions. Most of them are also related between each other, so they are mutually related and related to HPV 16, 18 or other high-risk HPV infection. Early age at first intercourse, multiple sexual partners, or having a male partner who had multiple previous sex partners and is therefore a high-risk male. We generally mention HPV 16 and 18 as high risk because these were the most common, but you have a number of other HPVs like 31, 33, 35 and others which are also high risk, so often associated with CIN and invasive carcinoma. These HPVs are detected in 85 to 90% of precancerous lesions or invasive neoplasms. These HPVs, papillomaviruses, are high risk because they form proteins which interact with the normal cell cycle regulatory proteins. high-risk HPVs express the proteins E6 and E7, which through a number of mechanisms inactivate p53 and retinoblastoma tumor suppressors and result in increased proliferation and decreased apoptosis initiated by DNA damage. As another gene involved in cervical carcinogenesis, there is also loss of LKB1. Cervical intraepithelial neoplasia is graded CIN 1, 2 or 3. Earlier these were called mild dysplasia, moderate dysplasia or severe dysplasia, including carcinoma in situ. On this picture you can see what CIN refers to. This is related to the lower third of the epithelium. CIN2 involves at most the upper the lower 2/3 of the epithelium, sparing the upper third of the epithelium, but these are atypical, obviously atypical cells with suprabasal mitosis like here and here, and CIN3 refers to the involvement of the upper third, generally the whole thickness of the epithelium, and this is also CIN3. Probably a bit more severe lesion as the one depicted here. Both of them are CIN3. This was referred to as carcinoma in situ earlier. Coelocytes are superficial cells associated with HPV infection, and if we go back here we also see coelocytes here. These are sometimes binucleated cells with a halo, white halo around them, and these coelocytes are very suggestive of a human papillomaviral origin of the lesion. They are also seen in cervical smears, and cervical smears cytological examination introduced by Dr. Papanikolaou is a way of detecting early lesions, precancerous lesions of the cervix, and allowing a decrease in mortality due to cervical carcinoma. Precancerous lesions may be picked up with cervical screening, and the changes which are present in CIN lesions are present for many years before the thing becomes an invasive carcinoma. This may cover a range of years up to 20 years, so dozens of years. In cervical specimens, cervical screening specimens, cytology specimens, we distinguish between squamous intraepithelial lesions of low grade and high grade, so low cell and high cell lesions. High cell lesions would include histology of CIN2 and CIN3, whereas low cell lesions will cover CIN1. This is a pap smear of coelocytes. Here you see an enlarged nucleus, a perinuclear white halo. You see a multinucleated cell here. These are very characteristic of human papillomaviral infections. Often low-grade CIN lesions have these changes. This is somewhat more atypical because you have normal squamous cells here, but you have enlarged nucleated cells in groups. Here again, these are atypical cells that you tend to pick up by screening to detect CIN lesions. The progression of CIN to invasive carcinoma is not obvious. CIN is not an obligate precursor of squamous cell carcinoma of the cervix. It may progress, and the higher the grade of CIN, the higher the rate of progression towards invasive carcinoma, but even CIN3 is not an obligate precursor. This takes quite a lot of time till this progresses to invasive carcinoma, and this allows us to pick up the lesions earlier. CIN is not associated with symptoms. The only way to pick it up is to screen. And for this screening, colposcopy is used by the gynecologist. So this is a kind of endoscopic examination without specific instrumentation. And the other way to detect CIN is by Pap smears, taking gynecological cytological smears and examination by morphology microscopy. If a low SIL is detected, this is generally managed conservatively with follow-up, but high SIL lesions are generally recommended surgical excision and follow-up after it. As you may be aware of this, HPV vaccination has been introduced, and the vaccine covers the four most common types of HPVs, low-risk HPVs and high-risk HPVs together, and obviously immunization against these HPV types will lead to a decrease in diseases caused by these viruses, but will also result in a shift of viruses which will cause CIN and cervical carcinoma. Other subtypes which we do not immunize against will probably rise in incidence. The gross morphology of invasive cervical carcinoma may be of three types. Fungating exophytic tumors may occur, so these are warty tumors. Often those associated with HPV are fungating, but also quite commonly we see infiltrative tumors without anything protruding into the lumen. And we also have ulcerative tumors as a possibility. These carcinomas develop in the transformation zone with which we started the pathology of the cervix, and sometimes they may be circumferential, encircling the cervix and penetrating deep into the underlying myometrial tissue, causing a barrel cervix, a very firm obliterated cervical canal. Cervical carcinoma is characterized by local spread. It may spread upwards towards the uterine corpus, backwards towards the rectum, and to the anterior part it may involve the urinary bladder, and this is quite commonly occurring. This may lead to urinary tract infections, ascending infections, and sepsis of urinary tract origin. Metastasis may be lymphatic to pelvic lymph nodes or hematogenous to the lung, liver, and bones. This is an example of cervical carcinoma. You can appreciate the tumor here. It's fungating, and if we look this from the vagina, this is how it looks like. It completely obliterates the orifice, the external os of the cervix. This is a cut surface of the same tumor, and you can appreciate that this whitish tumorous area practically leaves no normal cervical myometrium. Most tumors of the cervix, most carcinomas are squamous cell carcinomas, and they generally evolve from CIN lesions. The remaining are adenocarcinomas, which also have a precursor, adenocarcinoma in situ. These are less common, but all are associated with HPV infection. This is an invasive squamous cell carcinoma, which is non-keratinizing, but sometimes keratinization may also occur. A common symptom of invasive carcinoma is leukorrhea. Another one is bleeding from the uterus, vaginal bleeding. Dysuria may be a symptom after urinary tract involvement, or just because of the uterine size increases. As mentioned before, mortality of cervical cancer is generally not because of distant metastasis. Most commonly it's due to the local effects, and especially involvement of the urinary tract and urosepsis. The 5-year survival of tumors which are detected in an early stage, in the in situ stage, is 100%, so it is curable as a disease. Advanced stage with rectal or bladder involvement have a very poor prognosis. This is a case which resulted in the involvement of the urinary bladder, dual or both-sided ureteral obstruction, and hydronephrosis of both kidneys. We get to the uterine corpus, and we start with endometrial pathology, infection, inflammation of the endometrium is endometritis. The endometrium is resistant to inflammation, infections, because in the menstrual cyclic shedding of the endometrium, there is also a shedding of anything that invades through the endometrium. So even the bacteria which lodge in the endometrium are shedded. Acute endometritis needs some predisposing factors, for example, parturition, so giving birth, miscarriage, abortion. When this occurs, there are often products of conception, some residual parts of the placenta which remain in the endometrium. They become necrotic and are a good place for bacteria to grow in. But when this is evacuated with curettage, then the endometritis ceases. So acute endometritis is an uncommon disease. Chronic endometritis is also not very common, is often associated with gonorrhea, chronic gonorrhea of the pelvic organs, including the fallopian tube or cervix, and this may also involve the uterine corpus, the endometrium. Tuberculous endometritis is a granulomatous inflammation, but often reaching the endometrium from the fallopian tubes. Intrauterine contraceptive devices are also predisposing factors to inflammation as something alien in the body. And obviously there is a minority of the endometritis cases which cannot be associated with any of these predisposing factors or infective agents. The histology of endometritis is like inflammation anywhere in the body, but the diagnostic cell population for diagnosing chronic endometritis, we need the presence of plasma cells. Lymphocytes are nearly always present, but they are present even without endometritis. Plasma cells must be there to make the diagnosis of endometritis. Endometritis is associated with fever, pain, bleeding abnormalities, and may be also associated with inflammation of the fallopian tubes, and as a consequence of this fallopian tubal inflammation, salpingitis,
this may also be associated with sterility. Chronic endometritis diagnosed on the basis of plasma cells. Plasma cells are not that obvious within this population of mononuclear inflammatory cells, but may be highlighted with an antibody called CD79A, and you can also see that these plasma cells express both kappa light chains and lambda light chains, so this is a polyclonal proliferation of plasma cells, which is a non-neoplastic proliferation. Adenomyosis refers to the invagination of the deeper parts of the endometrium, the basal layer of the endometrium, into the myometrium. First sign of adenomyosis include endometrial stroma, which is a CD10 positive population of cells, and also endometrial glands within the stroma. As the basal layer does not demonstrate cyclic changes, cyclic bleeding into these glandular nests is generally not seen. Clinical symptoms of adenomyosis include bleeding disorders, pelvic pain before the onset of the menstrual bleeding. This is an example of adenomyosis. You see the endometrium here. This is already the myometrium, and the myometrium has an island of endometrial glands surrounded by endometrial stroma. This is a higher magnification of a similar lesion. You have the myometrium here, and this is endometrial stroma and an endometrial gland deep in the muscular layer of the uterus. Endometrial hyperplasias are non-neoplastic proliferations of the endometrium. They are often due to an imbalance in hormones or the hormonal surrounding, with an excess of estrogens relative to progesterones. This may be caused by failure of ovulation, which is quite common around the menopause, prolonged administration of exogenous estrogens, or production of endogenous estrogens by ovarian lesions, for example ovarian tumors. There are several types of endometrial hyperplasia. One of them is the simple hyperplasia, which is characterized by a thickening endometrium, which can be detected by ultrasound, measured by ultrasound. This is composed of cystically dilated glands. And there is also complex hyperplasia. Complex hyperplasia has architectural distortion, architectural atypia, which is due to back-to-back glands, so glands which are very close to each other without intervening stroma. Complex hyperplasia is often associated with cellular atypia, and then we get to atypical hyperplasia, which is nowadays called endometrial intraepithelial neoplasia. This is simple hyperplasia, cystically dilated glands which are lined by multi-layered glandular epithelium, and obviously the thickness of the endometrium is also increased in these cases. Endometrial hyperplasias of different type are associated with the development of endometrial carcinoma. Simple hyperplasia has a very low risk of adenocarcinoma associated with 1 to 3%, and this is mostly related to the excess of estrogens which produce both the hyperplasia but also a risk factor, as you will see, for endometrioid carcinoma of the uterus. By contrast, atypical hyperplasia, so complex hyperplasia with cellular atypia,
is associated with 20 to 50% risk of developing adenocarcinoma of the endometrioid type, and this is often associated with loss of function of the P10 tumor suppressor, and this is a relatively early step in endometrial carcinogenesis. As concerns the clinical symptoms of endometrial hyperplasia, sometimes there is no symptom. This is just detected by ultrasonography, pelvic ultrasonography, an increased thickness of the endometrium, but very commonly this is abnormal abnormal bleeding from the uterus, and this is voluminous and often occurring at an age where the bleeding, menstrual bleeding, generally diminishes. So menopausal ladies developing excessive bleeding might have endometrial hyperplasia, but may also have endometrial cancer, and histology will decide which is the lesion they have. Tumors of the endometrium, you have to remember that not only endometrial hyperplasias, but also tumors lead to abnormal bleeding. Benign tumors include endometrial polyps, which may be sessile or pedunculated lesions. They also lead to uterine bleeding. They are very, very uncommonly associated with carcinoma. They are kind of hyperplastic benign lesions. This is an example. There are endometrial glands in these polyps, and often at the base of the polyp we can distinguish thickened walled vessels, and these are diagnostic of polyps even in gratings where you don't see the whole lesion. Endometrial carcinoma is divided basically into two large subsets. One of them is endometrioid carcinoma, resembling the normal endometrium, and the other is serous carcinoma. These are two tumors with major differences in etiology and behavior. Endometrioid carcinoma is frequently associated with endometrial hyperplasia. Not the simple one, but more the complex and the atypical one. This has as a background an estrogenic effect. There is often a condition leading to excess estrogens in endometrioid carcinomas. Mutations in mismatch repair genes and loss of function of the P10 tumor suppressor gene is a common event in endometrioid carcinoma. Risk factors include obesity, diabetes, hypertension, infertility, a prolonged estrogen replacement therapy, or estrogen secreting ovarian tumors. Many of these, including obesity, are associated with an excess of estrogens, endogenous or exogenous. Endometrioid carcinoma may have two types of gross manifestation. It may be infiltrative or may be exophytic. As the name implies, it resembles endometrioid glands, is often estrogen receptor positive, as shown on this picture. These are neoplastic endometrial glands with not much stroma between them. Serous carcinoma, by contrast, arises in older women. There is usually no hyperplasia, but more commonly atrophy of the endometrium, which is associated. The genes involved are different. Often we see a mutation in the TP53 gene, which results in an aberrant p53 protein and loss of apoptotic functions. These are more aggressive tumors. Grossly, they are also either exophytic or deeply invasive. Microscopically, they are often papillary in structure, at least partially, and there are also glands with marked cellular atypia in these tumors. This is serous carcinoma of the uterus. You can see the cellular atypia here, and you can also discriminate the papillary structure of this lesion on the picture. Endometrial carcinoma spreads locally to the uterine cervix, periuterine structures, the parametrium, and it gives metastasis to pelvic lymph nodes or distant organs. Hematogenous metastases develop in the lung and liver. As mentioned earlier, the most common presenting symptom is uterine bleeding. Serous tumors have a worse prognosis, are generally of higher stage at the time of detection. Endometrioid carcinoma, especially those of low grade, have reasonably good prognosis. And that's the end of this part of the lecture. Thank you.